I will be giving you a broad overview of shoulder examination. Now, while this examination may not exactly conform to the kind of examination you may be required to present in a MS exam or a DNB exam, but this examination, the purpose of this is to at least make you understand in your daily OPD settings when you get a patient with shoulder pain, what all should go in your mind as you are listening to the patient and as you are examining the patient. Now, the reason why the shoulder examination is so important is because a lot of diseases overlap, pain and stiffness overlap in the shoulder joint. Investigations sometimes lead you to unreliable outcomes. So shoulder is a unique joint in the sense that the time when the patient has come to you, he or she may have a significant overlap of pain and stiffness that increases your difficulty in diagnosing common shoulder conditions because of the presence of stiffness and because of the presence of severe pain. You may not be able to do the special test that one is usually able to do in a painless and a fully mobile shoulder. Now, one very common mistake all of us make is to straight away read the MRI report without bothering to listen to the patient, without bothering to examine the patient. And well, I'll give you a simple example. This is a MRI report. This is the kind of MRI report you receive. And you see a lot of conditions mentioned in this report, and it's not the fault of the radiologist. The radiologist can only interpret the images and tell you what he or she thinks is the pathology. It is your job to find out that pathology, preferably in the history itself, and confirm it in your clinical examination. The problem in the shoulder may actually be elsewhere. Very commonly, we find that pain in the cervical spine, pain distant to the shoulder is responsible for shoulder pain. So learn to see the patient as a whole so that you are able to identify or able to diagnose the kind of problem your patient is suffering from. Cyriax is the author of a very popular injection manual, and he rightly says that the shoulder joint is the most honest joint and it is the most curable joint of the human body, provided you are able to diagnose its problems. One reason why the shoulder problems may be a little difficult to diagnose, as Dr. Tim Bunker puts it so eloquently, is that it is buried deep under the cloak of the rheumatoid and it remains till date upon your patient. So you need to develop this habit of active listening to the patient. You need to expose the patient properly, which is not a problem with a male patient. The practical difficulties come with a female patient, that to a young female patient. You must have a gown or at the least a opaque bed sheet so that you can instruct the lady to cover the chest in order to preserve modesty and yet be able to examine the shoulders fully. And instead of relying on one particular test or one particular symptom, develop a cluster approach. A cluster is a group of 2 or more signs and symptoms which lead you towards a diagnosis. None of them in isolation is diagnostic, but all of them in combination give you the right set of mindset to approach your patient and to arrive at a clinical diagnosis. A lot of people, a lot of clinicians, you may have seen some of your seniors trying to cure shoulder problems without properly diagnosing them by just giving a blind steroid injection. It generally doesn't result in long-term satisfaction. The patients may have a temporary relief in pain as a result of the injection, but it doesn't result in long-term problems. And when you operate upon your patient, it should be for clearly defined indications only, because there are a lot of patients who are dissatisfied with shoulder surgery, and you must operate them only when you are very clear in your mind that the diagnosis is clear. You have tried a period of non-operative treatment, and then you have defined that yes, you can make this patient better by operating.